Today's lecture is about bimaxillary protrusion. So what is bimaxillary protrusion? It's a condition characterized by protrusive and proclined upper and lower incisors, increasing the prominence of the lip, and usually this one is shown in African American, Asian population as well, and it can be found almost in every ethnic group. That's according to Leonardi et al. That's a systematic review. Usually these patients have an interincisal angle of 115, less than that, or the upper incisors are proclined more than 118 and the lower incisors proclined by 97 and more. As I said, it can be seen in the Afro-Caribbean, it can be seen in Asian and Arab population. However, it's less prevalent in the Caucasian population. So there has always been a debate about the terminology proclination or protrusion. Now generally when you say proclination, it means that the bone are in correct position but the teeth are proclined. While when we see protrusion, it means that the skeleton, the skeletal base is moved forward. So when I say bimaxillary proclination, it means that the teeth only are moving forward. When I see protrusion, it means that the basal bone carrying with it the teeth are moving forward. However, this paragraph is taken from Prophet, a textbook. He said bimaxillary dentoalveolar protrusion, hereafter called just bimaxillary protrusion, as in most of the orthodontic literature. So from now on, we're just gonna say bimaxillary protrusion, and this terminology will indicate either incisor proclination or bony protrusion. So this is exactly what we are talking about. This is the normal interincisal angle, but this is what happened with bimaxillary protrusion. The upper incisors are proclined, lower incisors are proclined, the interincisal angle is reduced. Now the effect of this one will be on the profile of the patient, and this is kind of classical typical photo of a patient with bimaxillary protrusion. As you can see, the teeth are pushed, or the skeletal are pushed forward, straining the lips that are covering them. So the patient here has an incompetent lip and the patient is struggling to bring the two lips together to meet. So why is that? Why do we have bimaxillary protrusion? The first, definitely like most of malocclusion, there's no clear etiological factor, but genetics play a major role, because you can see it in Afro-Caribbean, you can see it in some Arabic population, Asian, but you see it less common, less often in the Caucasian population. So there could be a genetic issue. Soft tissue as well. These patients usually they have thick, everted, and weaker lips, because as I say here, according to Naini and Jill, in bimaxillary proclination, lips are often full and everted. Tongue exerts pressure on the teeth so that the dental arch is moving forward. So we know from the equilibrium theory that the teeth are in a state in equilibrium between the pressure of the tongue and the cheeks and the lips, and the periodontal ligament act to stabilize them. So when the lips are weaker than the tongue, as we can see in this case, the tongue will push the incisors forward. Habits, for example, tongue thrusting, as you can see when the tongue is resting between the upper and lower incisors, causing an anterior open bite and proclination of the upper and lower incisors. However, we have discussed that when we discussed the etiology of the malocclusion, and we said that which one before, the chicken or the egg, and it's the same. Is the tongue being the bad guy who's causing this problem, or is the tongue being a good guy who's trying to compensate for the already malocclusion? We still don't know that, but what we know for sure, that if it's an endogenous tongue thrust, or the patient has a symptoms which the tongue is bigger and resting between the teeth all the time, it is definitely an etiological factor. Dental factor, the tooth size arch length discrepancy can be expressed in the form of the proclination of the incisors. So what does that mean? Usually the teeth, they are well aligned, as you can see here in the picture, but these teeth are pushed more forward, causing the bimaxillary inclination, as you can see in the picture. When the teeth are pushed forward, they're creating more space for the teeth to be aligned. So what's going to happen, that the teeth are in a more labial position and more oriented labially, which going to create more space for the teeth to be aligned. So we'll have a bimaxillary proclination. So that will relieve the crowding, but in the same time it will cause proclination and protrusion of the incisors. For that reason, somebody will call the bimaxillary protrusion as something we call it hidden crowding. The crowding that you can see because the teeth are proclined and protruded. If you have a systematic disease like cancrum oris and the syndromes that can affect the soft tissue of the lips, make them weaker, the tongue will cause pushing of the incisors. So what are the features of the bimaxillary protrusion patients? There's two papers here describing this one, Carter 1988 and Keating 1986. They looked at the sample with bimaxillary protrusion and they found usually even though they have a protrusion of the incisor, it also has intrusion of the skeletal base as well. So the maxilla and the mandible will be protruded. However, the maxilla will be protruded more than the mandible. So the A and B will be more than 4. So the patient will be more into class 2ish. However, that's in most of the cases, but not all of them. So you can see bimaxillary protrusion with a class 3. But in most of the cases, what's going to happen, the maxilla is protruded, the mandible is protruded, but the maxilla is protruded more, so you get the class 2ish. And not only that, the anterior-posterior dimension of the maxilla and the little X of the mandible are larger. So they are not only protruded in the position, but they are bigger in size as well. They have short posterior cranial base, and usually the patient with a bimaxillary protrusion, they have a divergent face, which means posterior growth rotation, reduced overbite, increased lower facial height, all these features of a posterior growth rotation. What about the soft tissue? They will have a convex profile, as we said, because the maxilla is bigger than the mandible moving forward, and the lips are slightly longer. They have a longer lip compared to the normal population, and obviously more protrusive. More protrusive because of the underlying protrusive teeth and bone. However, if you measure the thickness of the lips here at the A point and at the B point, it is the same as patients with no bimaxillary protrusion. So why the lips are protruded? It's because of the underlying soft tissue, hard tissue and teeth, and as well because of the longer eversion of the longer lips in the anterior area here of these lips. So that's why these patients will have a protrusive lip, because they have a longer lip, they are everted, they have the protruded incisors and the bony tissue posturing everything forward. What about the dental feature? As we said before, bimaxillary protrusion and proclination. So you have the upper incisors moving forward, and the angle of them as well are proclined. Now, because we said that the patient might have a skeletally class 2 because the maxilla is more protruded than the mandible, so that we are expecting more proclination in the lower arch compared to the upper arch. Again, because of the proclination, you can see that the overjet will be increased. So these are the same teeth, but then here, just changing the inclination from here to here, the overjet will be increased as well. The patient will have a larger dental arch length. That's obvious because the teeth are pushed forward. They will have a steeper mandibular plane angle because of the posterior growth rotation. And they will have, in most of the cases, normal molar and canine relationship. As you can see, class 1 molars, class 1 canine. And why is that? Because simply, all that's going to happen, these teeth are crowded and then they are pushed forward, so the teeth are well aligned, no crowding, and then everything is class 1, as if you're doing a sitting of teeth. So they are well aligned but just moved forward. These teeth are on average larger in size compared to the patients who have no bimaxillary protrusion, and when they are larger in size, that's give more or exacerbate the facial appearance of the bimaxillary proclination, because they are not only pushed forward but also they are bigger in size. So what is the management of the bimaxillary protrusion? The management should be around moving the incisors posteriorly to try to reduce the strain and the protrusion of the lips. So that most of the time, a few exceptions, will have to be done with extraction of premolars, and because the patient usually have a class 1 molar relationship, so that means that we have to do extraction in 4 quadrants and retraction of the incisors posteriorly to achieve an optimal improvement in the dentofacial appearance. So if you have a patient like this, all what you need to do is to take out teeth. As you can see, that's a profit. Again, retract these incisors until the soft tissue are improved. Now, how much the soft tissue will follow the extraction, we will discuss this at the end of this lecture. So when we decide to treat the patient with a bimaxillary protrusion, the management should be depending on how much do I need to retract these incisors to achieve good aesthetic results. Meaning, for example, for this patient here, if you reinforce anchorage and you over retract the incisors, the patient will have a dished in profile. So you need exactly to measure how much you need to retract the incisors, and that will be set up as your treatment aim. So for that reason, we divide the treatment with bimaxillary protrusion on patient with moderate anchorage situation. And this is kind of most of the patient, the Caucasian one particularly, fall, because you don't need to do a lot of retraction. So what's going to happen is, don't reinforce anchorage, extract the first premolar, and that will give you almost 50-50 of the space for the anterior segment and the posterior segment, or 60 for the anterior and 40 for the posterior, without reinforcing of the anchorage, and by that you will achieve the retraction that is required to treat this malocclusion. We call this as a moderate anchorage demand. As you can see here, Prophet recommended that in these cases you retract the canine first. So you do that in 2 stages. First stage of canine retraction, then the canine back into class 1, closing the extraction space, and then you get a power chain from the 6 to 6 to close the spaces. If you follow this technique, you are expecting to get 50%, 60% of the spaces for the anterior teeth and 40% of the space for the posterior teeth. However, I just want to make it clear that these numbers are only to guide you during the treatment plan, and always there's a personal variation. So each time when you do this, you need to observe your anchorage, and you need to monitor if there is any anchorage loss. But if you do in mass retraction, that for example you have a power chain from 6 to 6, the maximum you can get is 50-50. And again, this is according to Prophet textbook. If you engage the second molar, you will increase the anchorage by increasing more tooth. So you increase your anchorage unit, you get more retraction of the incisors. And remember, if you need to add more torque to the incisors, that more anchorage demanding to retract them. But if they are proclined at the beginning and they're gonna retrocline a little bit, this is less anchorage demanding, which works in our side at these cases. So for example, this is the patient again from Prophet textbook. If you do the extraction, retraction, and this is how the patient profile improve. But look at the superimposition of the lateral curve. This one here shows you the amount of incisors, of the molars and incisors movement on the maxilla. So this one is before, this one is after treatment, and this is before treatment. So as you can see, there is an anchorage loss in the upper arch. And in the lower arch to a lesser extent, and you can see that the lower incisors were retracted and the upper incisors as well. But the point here is that we did not use a full anchorage to over retract the author did not do an over retraction of the incisors, so he allowed these molars to move forward. But some cases, no, we need to achieve maximum retraction of these incisors in order to achieve maximum improvement of the patient's profile. So what you need to do is to set up your goal, saying that, okay, for example, in this patient, I have to move these incisors posteriorly 4 to 4.5 millimeter, which requires about 8 millimeter of space, which means that you need 4 millimeter of space on each side. Now, this anchorage demand will be increased, and the demand for anchorage will be increased if the patient has crowding, because then you need space to correct the protrusion and space to correct the crowding. So remember, in the cases in which we don't have crowding, we have well-aligned dentition. In most of the cases, we don't have to reinforce anchorage. But when you have a bimaxillary protrusion case combined with the crowding, that means that your demand for space is more, because you need the space to retract the teeth, correct the bimaxillary protrusion, and you need the space to relieve the crowding. So how can we do that? First, you can use the reinforcement with stabilizing arch wires, lingual arch. For example, lingual arch in the lower arch. We can use transpalatal arch in the upper, or Nance appliance. We covered this in the anchorage, and we know from the evidence that Nance is good and effective in maintaining anchorage. However, lingual arch and TPA are not. we can use a headgear to reinforce anchorage. And here you have two ways of using headgear. The first one is to have the headgear directly inserted to the upper to hold the posterior teeth, and then use a power chain to the incisors to retract them and move the incisors posteriorly. The upper teeth are held by the headgear. And at the same time, you can use a headgear that is attached to the lower arch, which will be more difficult for the patient. So the solution for this problem is headgear in the upper, and then you go and use class 3 elastics between the lower and the upper arch. Now when you do that, the class 3 elastics will tend to move the lower teeth posteriorly and the posterior teeth forward. Now because the patient is wearing the headgear, these posterior teeth will not move forward. It will be maintained in its place. So now the lower incisor will be retracted without any reactionary forces in the lower arch. So kinda in theory you can get 100% retraction of the incisors. But this requires extreme level of patient's cooperation. He has to wear the headgear, he has to be committed to the elastics. It's a lot of commitment that the patient should do. Now, according to Profit, again, if you use this technique, the space closure, you get 3 to 1 or 4 to 1, which means like for 4 millimeter retraction in the upper, you get 1 millimeter space loss in the upper as well. Or you can use something, you call it 2 steps frictionless retraction. So basically what you do is, first you retract the canine, but then you retract the canine with the loop mechanics that you don't have to slide the canine on the wire. We call it frictionless. So why is that? Because when you try to move the tooth, you need to apply force to overcome the amount of friction between the tooth and the wire. And then you need to apply force to start moving to the tooth. Well, if you're using a loop mechanics, the force you need is just to move the tooth. You don't need force to overcome the friction. So let's say that I want to move a canine on the regular mechanics. I have to use a power chain to the canine with an amount of force, for example, 120. 60 gram, again for example, will go for friction, and 60 gram to move the canine. When you apply 120 gram, you are expecting a reactionary force on the molars with the same amount. But if you're using a frictionless technique, which means that you need only 60 gram to move the canine, because now you don't have to overcome the friction, so you don't have to apply a 60 gram more. So you need to apply only 60 gram, not 120. Now, the reactionary force on the molar are the same amount, which is 60 gram. So in the frictionless technique, the amount of the force that you're applying to the molar is less, which means less anchorage loss. Once the canine is retracted, the anteriors are retracted as well using frictionless technique and closing loops. The other method and the last method is to use TADS, skeletal anchorage, in which you retract the upper and lower incisors to correct the protrusion of the incisors. So if you can see a patient here, again, we set up the rules. He has a protrusive lips. We need to retract the incisors by around 4 millimeter. We have a little bit of crowding need to relieve. TAD is used to retract the incisors. And here is my protocol when I do bimaxillary protrusion. I do band the 7s in the lower and use TADs in the upper. And why is that? When you band the 7s in the lower, you have 7, 6, 5 against 3, 2, 1. And these teeth are much bigger than these teeth, so you're expecting more movement of the anterior segment. This is number one. And number two, and I know it is a theory, but I just feel it works sometimes, that when you retract the incisors, because we have a positive overbite, and using TADs, you're retracting the incisors and you're retracting the lower, the upper incisors will hit the lower incisor, kind of give them a little bit of nudge to move along as well, so kind of helping to do the space closure by the anterior teeth moving posteriorly. So as you can see here, the amount of the patient's profile improvement. So yeah, extraction and retraction, it will improve the bimaxillary protrusion. However, you should know that the response is variable, and whenever you treat the patient with bimaxillary protrusion, we know that there will be improvement. Definitely we will have an improvement, but how much improvement are we going to get? That's a question that we don't exactly know. But what we know from evidence, that when we do extraction, at least the lips will become competent. So if the patient has a protrusive incisors to the point that the patient don't have competent lips, once you retract the incisors enough amount, you will improve the lip competency. This is the patient after we finish treatment, class 1 molars and canine. But the only disadvantage with using that, and this is a thing that you need to be careful whenever you are treating a bimaxillary protrusion case, is not to do over retraction. What does that mean? So if you see this patient, for example, she has slightly protrusive lips. However, the lips are thin and she has an increased nasolabial angle. She does not like the protrusion. She has a bimaxillary protrusion, anterior open bite. She wants her teeth to move back. Just remember that the lip here is thin. So I decided to say, okay, I need to do maximum retraction of the incisors to improve hair profile. So what I did is I used TADS and I did maximum retraction. So but what happened? Dentally everything is fine. I feel that I kinda over retracted the incisors. As you can see here, the nasolabial angle is increased, the lip become thinner, and the lower lip is retracted as well. Now the patient is very happy and very satisfied because she was complaining all her years from the protrusion of the upper and lower incisors. However, when I look to the case, I say, oh no, I think I over retracted my incisors. I should have retracted them, but with a little bit of amount, not as much as I did this time. So the lesson that we have to learn, that we need to retract the upper incisors, but we need to retract them the right amount, not to cause a bimaxillary retrusion of the incisors. So stability. Once we finish treatment, how stable is our results? First thing, equilibrium theory. Remember from the etiology we said that the tongue is stronger than the lips on this patient, so the tongue is pushing the incisors forward. Now when you do a treatment for these patients, you're extracting the teeth and then you're retracting everything posteriorly. So you are kinda moving the teeth into the tongue space. Moving the teeth into tongue space, meaning that the tongue will push the teeth again anteriorly, which will result in more space opening and more proclination. To try to limit, so it's fairly unstable. That's what I'm trying to say about the bimaxillary protrusion treatment. To improve your stability, you need to have the lower lip covering the upper incisors after we finish the treatment. By that, you can give a help to the incisors to stay where they are. While if the lower lip is not covering the upper incisors after we finish the treatment, that means that the upper incisor will easily move forward. The recommended retainer in these cases is using vacuum formed retainer with a bonded retainer. Remember that you have an extraction spaces, so you either reinforce wearing the vacuum formed retainer and the patient should not miss it for the extraction space not to reopen, or you extend your bonded retainer into the premolars. The last question is, does orthodontic treatment of bimaxillary protrusion improve the soft tissue profile? Well, this is a random systematic review by Leonardo, and what he found is, we covered this one in the extraction lecture as well, it's the same paper. When we do extraction and retraction, the upper lip are retracted by 2 to 3 millimeter, where the lower lip will be retracted by 2 to 4.5 millimeter. Lip competency improve following the extraction, and this improvement is predictable, and that's what we were talking about. So you can guarantee that to the patient that the lips will be competent, the stretch of the lips will improve. However, the changes are small and it does not dramatically affect the patient's profile. The patient will not have a dished in profile. Okay, and there is a huge individual variation. So what should we tell the patient who's seeking treatment for bimaxillary protrusion? We're gonna tell them that we need to do extraction, we're gonna retract your incisors, the lips will follow, but how much the lip will follow, that's the things that we don't know. The thinner the lips, more they will follow the incisor, but this is different from one patient to the other. However, your lip competency will be improved and the protrusion will be improved, but how much improvement do we get? We don't know. It depends on the type of the soft tissue. Thank you very much.